Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast today. My name is Terry Fletcher. I hope everyone is having a great day and enjoying our beautiful weather across the country. I know it's probably hotter for you, some of you that are on the East Coast than those of us on the West Coast, but it actually cooled down from the last time I talked to you, over 100 degrees before, but now we've been in the really nice high 70s and great ocean breezes. So hopefully everybody's been out to enjoy that. So today we're actually at Top 10 Tuesday because it's the last Tuesday of the month and it is the 145th CodeCast episode. And so we want to really dive in. There's a lot going on. I want to focus on the headlines today. So that's going to be my top 10. And then also letting you know some of the things in the news that just came up because I don't want you to have to always go search it out. So if you're a Coding Corner client, you received a couple of emails from me last week on a couple of things. So hopefully those of you that are still interested in that, we're getting a lot of traction, getting more and more Coding Corner membership clients. And we really appreciate all of you that are becoming members of Terry Fletcher Consulting. So it's great to have you. What I want to bring to you today, not only in the headlines, but just some of the things that have come out with regard to coding. And this is interesting because we had some new ICD-10 codes that became immediately effective because of the COVID pandemic. And that is unusual. Even when things come out that are new, they always wait until it's supposed to start. So with ICD-10, it's October 1st. Well, AMA, and that's CPT, they issued 3 new COVID lab codes, including a nasal swab assay that took effect immediately, which means after June 25th. And so one is a Category 1 code. And Category 1 means it's our usual CPT code, and that's 87426. And then we have 2 new PLA codes, 0223U and 0224U, which are the 2 new proprietary, quote, air quotes there, U codes, and that's to test patients for COVID-19. So the Category 1 code 87426 may be reported for multiple types of qualitative or semi-qualitative immunoassay techniques. And then the U codes, the 2 new proprietary, meaning only for lab analysis. That's what PLA is, proprietary lab analysis. And these 2 new codes allow for a more detailed analysis. So for example, 0223U allows detection of multiple respiratory pathogens via nasal swab. And the code 0224U reports a test for qualitative and quantitative COVID antibodies in the blood and blood serum and may be used to find candidates with higher titer against the virus. So I had a antibodies test because those of you, I actually put it out there. I did have COVID at the beginning of February. Gosh, can you believe that's almost 4 months ago? During Super Bowl weekend, that was a good time. But I did have 2 antibodies tests actually. And it's interesting because the antibodies actually change. Obviously, it's almost just like having a flu shot. How immune are you at certain points after you've had the actual virus? But at least I know that I did have it and I've given plasma. But so those are some of the new things that have come out just from a lab test perspective. Number 2 on our top 10 list is a federal appeals court ruled the federal government has the authority now to cut Medicare payments to off-campus clinics to bring them more in line with independent physician practices. And a lower court's decision said that they didn't have the right to do that because the U.S. Appeals Court for the District of Columbia, so Washington, D.C., delivered Friday, struck a blow to the hospital industry, basically saying, look, you can't get paid more than a physician practice. It's not appropriate. And so what happened is that a lower court had agreed with the hospitals that HHS did not have the authority to make the payments. But then the appeals court found that HHS did have the authority because federal law gives HHS the power to control unnecessary increases in the volume of covered outpatient services. And so the reason that this is such a big deal is that there's going to be budget neutrality or parity now where the reimbursements for the physicians should shift and should be there for them, not just giving to the hospital extension areas. So that's actually a good thing for physicians. Let's see how it all pans out, because now with pay performance and some of the things tied to that and ACOs, I'm not sure how it's going to pan out, but the end result was a good one. Number 3, so we know this because I mentioned this a couple of podcasts ago, but CMS will resume auditing healthcare providers' claims just in 2 weeks. And so actually, as of this podcast, it's going to be 1 week. And the agency performs a variety of fee-for-service claim reviews. And they usually do it through private contractors. I'm sure you've seen the RAC audits. They want to make sure that hospitals, physician clinics, and other healthcare providers weren't overpaid. And so this is part of their regulatory compliance rules. They have to do this. This is actually part of their integrity program. And so the federal government, as you know, eased a number of regulatory compliance rules during our pandemic to help providers, such as those guiding telehealth visits and not requiring signatures on durable medical equipment orders, and allowing more providers than ever before provide telehealth. But now what the administrator of Medicare has said is that they are seeing now that more visits than are physically possible in a day are being submitted for payment. And on my audits, I'm seeing that too. I've got clients that I'm like, you can't be sending me 12, 13, 14, 15 level 5 audiovisual or even, visits per day. Do the math, especially if you're trying to use time as your support for those visits. Also noted were questionnaires that were sent to the patients to ask them about their telehealth experience. And they said, was the audiovisual there? They found out that a big percentage of services billed as audiovisual office visits were actually phone calls only, audio calls. And now and because of the payment parity, this has cost Medicare, they estimate billions of dollars in overpayment. And if that was your practice, if you didn't basically take my instruction or do as you wanted, just assuming that nobody would find out, expect some refund requests and possibly penalties and fines. And then you'll be on a watch list. You just don't want to be there. Do you want to do it right? But regardless of where COVID is on August 3rd, CMS program audits are going live. And so they halted them for RAC audits, the supplemental audits, the TPE audits, and other pre and post payment audits. I know because since I audit for them, I know that this was definitely put on hold, but now I have an inbox full of when this is starting up again, and already 3 payers saying, okay, so we need you to audit this, this, and this. And so it's just part of their integrity program. They have to do it, and they cannot extend it just because of a pandemic. And so be aware that's coming. It's not if, it's when. Number 4, I just want to remind you that the 2021 E&M rule changes are now less than 6 months away. So I encourage you to go to my website and register for the 3-part on-demand training session if you haven't done it already. Part 1 is already available. Part 2 will be out in August, and Part 3 will be out in October. So I wouldn't wait if I was you. You need to get on board with this because it's coming. And they're not extending it. I've had a lot of questions on that. Well, aren't they going to extend it like they did, ICD-10? They're not. It's going forward. Number 5, and I'm getting a lot of questions and feedback. I put in a recent article on ICD-10monitor.com on preventative versus office visits on the same date. So for those of you that are primary care offices, internal medicine practices, anybody who basically does annual physicals that also may lead to a problem-oriented visit, it may be something you want to read through. So I know that one of the Medicare MAC carriers, Noridian, sent me an email about it to train their staff after they read my article. So check it out and see if you have any questions, and that should answer some of your questions on that. Again, ICD-10monitor.com. Number 6, be cautious about referring patients to a specialist and letting them know they can always do it via telehealth. So this happened recently. My husband had an issue this week where he was told he could see a specialist from his primary care doctor and said, you can do it through telehealth. And he's like, okay. So found a panel physician on our plan. And basically they set him up for a telehealth visit. And then he gets an EOB, and it turned out that they said, no, you owe $184 because you had to use our panel of telehealth physicians, not your own one, even if they were on the plan. And we were not aware of that. Now, he was able to fight it because in California, we have an executive order from the governor that says that they have to, if they allow for telehealth at all, it has to also allow for your own physician to provide it or a physician that is on your plan, and I can fight anything. So I just want to make sure that you're aware, though, that if you are a primary care office and you're referring patients to see a specialist and telling them try to get it via telehealth, make them aware that their plan may mean that they have to use their panel physicians, not a specific physician they want to go to. So just give the patients a heads up about that, because that's a personal thing that just happened that I want to make sure that you're aware of. And then number 7, okay, so telehealth is already being cut. After changing policies to cover telehealth more broadly during the pandemic, some insurers are already scaling it back, even as COVID cases surge in some states. So just a couple of examples, and I strongly urge you, whoever's in charge of looking at your insurance contracts, Blue Cross Blue Shield of Texas, where cases have soared in the past week, said in the last 2 weeks, their expiration date for expanded telehealth coverage is August 31st. We've got a couple more that are in September. I know United Healthcare. Aetna began changing patients' co-payments and cost sharing as of June 4th, even without notice. All of a sudden, as of June 4th, they didn't put it on their website to June 10th, and they said, by the way, it doesn't matter the reason. If it's under telehealth, patients will have a share of cost, and we're no longer paying you the allowable. And then Cigna said it'll end their expanded telehealth coverage on July 31st. Also, some Arizona insurers have decreased telehealth coverages as hospital ICUs filled with COVID-19 patients, and they are just saying that they want to offer telehealth, but not similar to the flexibilities in the Medicare plan. And so some employer health plans have not been required to expand telehealth coverage. But this is why I usually teach Medicare, because keeping up with all of the commercial plans, which I do, by the way, but it's hard to always instruct that. You need to for your individual contracts. Otherwise, your patients could be left with a very large out-of-pocket, and you could see some denials where you expected some payments. So make sure you're checking, and usually they have to put it on their website. So always check their website, look for COVID-19 coverage updates, and things like that. Otherwise, that will be definitely a problem. Number 8 is actually a coding question, and it was something about being still confused on the CS modifier. When we can use it for testing, labs, and procedures or treatment related to COVID. So the CS modifier means that you can waive the patient's share of cost under Medicare if they come in with a COVID, if they're having a COVID test, lab test, or if their visit is related to COVID testing because of sign or symptoms. They have to have it. It can't be a patient that, let's say, is suspected that could be, that's not a covered. They actually have to have sign or symptoms to be able to get tested to have the waiver of the out-of-pocket. But what happens, let's say, if you have a patient who had COVID and test negative, and 3 months later they come in complaining of some chest pain or something feeling a little bit off, and the doctor wants to do an echo because he or she feels that maybe their lingering feeling is now related to possible COVID. And I've heard that echoes are making huge insights and strides when it comes to post-lingering effects of COVID that is attacking the cardiovascular system. Is that something you can put a CS modifier on? It isn't, because it's not related to treating COVID or finding COVID. It's kind of in the fringes of, lingering effects or possibly related to COVID, but we don't know yet. So you really have to understand the guidelines, treatment for or testing for somebody that has symptoms or is sick with COVID. So know when to use that CS modifier. The audits, I wanted to give you just a few that came out as far as where they're going to be targeted, and this is number 9, but there's a couple under this number as far as what you're going to be looking at. So COVID-19 screenings. So this is based on the number of OIG, Office of Inspector General, investigations and settlement actions during the past few months. There's been so much fraud on COVID. It's really sad. But they said that they're going to be checking for screenings. One thing that's come out, and I know you kind of think it's probably just news propaganda. It's not. It happened to a couple of my daughter's friends and actually a friend of mine. People have been scheduling an appointment for a COVID test. They work in a place where maybe it's high risk. I mean, just somebody working at a Starbucks drive-thru, if they don't have masks on, or somebody in the, that's corresponding with them doesn't have a mask on, that's somebody that possibly could be exposed. And so there was a lot of times where the food service people are being told to make an appointment for a test, and then some of them don't show up, or they felt like one person told me that he had to wait in line for the test an hour and a half, and he had to get to work. He thought he could go in really quickly before work, and he left. Well, his place in line, they just kept putting through whatever your lottery ticket was. And he ended up getting an email saying that he was positive and he never had the test. So this is where the investigations are starting. Application of COVID-10 diagnoses and documentation to support the use of the codes. Because remember, ranking and sequencing is important as they are as a secondary and tertiary diagnosis use, because we have to make sure we know if somebody died with COVID or they died from COVID. Otherwise, the numbers are skewed, and we've shut down the economy. Our kids aren't at school, etc., because of numbers that aren't accurate. And so they want to go in, and of course now, because there wasn't any oversight when they started, they just pushed everything out there. Now they want to go back and check, which it is important. At least they're doing it now. Obviously, telehealth services are going to be targeted. We've audited a lot of these. I've audited a lot of these and my clients during the crisis, and the lack of documentation is really troubling to me, or basically the incorrect documentation. And don't just use the medical decision-making and the time to rely on the services. It's still the driving force. Yes, medical necessity is the driving force, but there still has to be some kind of history and exam, or some entry saying that you couldn't take the exam due to the audiovisual visit, but has to be able to see something on visual, right? I mean, especially if you're billing a high level of service. And I'm seeing that there's just not a lot there. Or I'm seeing over documentation where somebody's giving me information that they can't possibly see over a phone call or over an audiovisual visit. And I'm also seeing where there's no comment as far as what type of device they're using. There's no FaceTime. There's no Microsoft Teams. There's no My Chart through whatever your EMR is. If you're using Epic or if you used Skype, you have to put it in there. And the reason you have to put it in there is because under the waiver, it said that you had to inform patients that if you were not using a HIPAA-protected application or platform, that you had to let the patient know that they were compromised. And so if you're having these visits over, let's say, Skype or FaceTime with patients, and you haven't put that in your record, and then they go and talk to the patient or send them a questionnaire, and they said, well, I don't really like the Skype. I don't, like it over my phone or my tablet, or I'm only using a phone call, and it's not in the physician's record, you could be asked for a refund. And so because you didn't tell them that this is not necessarily HIPAA protected, as we know it isn't. And so there's rules, there's documents. That's why I've made sure that I've given my clients a script. You have to follow the script. This should be in every single document. Now, at any kind of telehealth visit. Now they relaxed something on the consents where you can have them once a year, but there should be something that says consent taken and then the date. I want it brought forward so I don't have to go look for it. But it's just some things there that you really need to know what they're going to look for. They want you to act in good faith. And then in-person encounters with minor procedures, they're always talking about the 25 modifier. And if it would be included, they really feel that dermatology, primary care, urgent care, ENT, podiatry, and orthopedics, they're at the highest risk right now. Surgical procedures, I think there's going to be a focus on some major surgery codes prior to the stay-in-place issued in many states, and the resumption of surgeries once the stay-in-place was lifted, because I think orthopedics may be at the highest risk here. So just be aware of that. So that's where your target's going to be, and you need to just have a kind of a heads up about it. And then number 10, and this is a positive. I definitely want to end my top 10 on a positive. We have the public health emergency has been extended. I sent out an email, as for those of you that are clients of mine, on Thursday, and then of course in the afternoon, and then at 4 p.m. Pacific time on Thursday, they threw a Hail Mary, and the HHS extended the public health emergency. And it didn't specifically say 90 days, but you should know, and put this in your back pocket, under the PHS Act, that's the Public Health Service Act from 1944, under Section 319, The rule says that when you renew that, it's up to 90 days unless otherwise specified. And so because they didn't specify it, we get 90 days. So that's at the end of October. And so August, September, October. Yeah. So just making sure. Now, in saying that, just know that the public health emergency was extended, but that doesn't mean all the waivers are blanketed extended. Remember, the waivers are individual under the 1135 exception rule. And so because we kept having more and more waivers added, remember? And so they can repeal individual waivers at any time. So make sure you're checking your EOBs for denials. Something may have expired that they didn't put on one of the office calls, but I don't want you to be blindsided about that. So I do have a coding question today, even though I did take one in my top 10. And this one is about a patient who suffered an ankle stress fracture. So the question is, should I use standard fracture ICD-10 codes, or is there a code set for stress fracture diagnoses? So stress fractures do have their own ICD-10 code set. It's in the section M as in Mary 84.3, and you're going to need an extra digit. Typically it goes up to the 6th digit because you're also going to need laterality. And so it could be M84.371, and then you'd need actually it could be another digit because you'd have to know exactly what kind of stress, but it does have its own section. So, and its own anatomical side as well. So check in that M84.3 area, and then it'll move you forward into what you need to know there. The CodeCast podcast is also brought to you today by Charles Schwab. Be a more informed investor. Follow us for news, insights to help you own your tomorrow about schwab.com. Okay, so I wanted to end with my personal tidbit this week. And first, I have two actually. So I was meeting with some cardiovascular physicians this week, and they're in a big meeting coming up. They're not happy. It has to be virtual. And they wanted to come up with some jokes. I thought this was really funny. So I thought I'd tell you what they told me. They're like, Terry, you have to tell us that this is funny. So here's one. It says, I'll tell you a vascular medicine joke, but I don't want to do the leg work. Ha ha. Okay. And somebody said, that's good. I had a cardiology joke too, but I didn't have the heart to tell you. I'm like, oh my gosh, you people. I have a cardiology joke, but it's a little tacky. Okay, so for those of you, TACHY, those of you that are cardiology based, you won't think these are funny, but it's kind of funny. It's the last one. I'd lie and tell you I have a cardiology joke, but that would be a fib. Okay, some of you might laugh at that one. Anyway, see, cardiologists think they can be funny. Not so much, but it was kind of amusing to me. And then I just want to shout out to my awesome listeners, my Facebook people, everyone who just really inspires me to keep this going. I received one of the most heartfelt emails, and it's too long to read, but it was just amazing, from Angie C., who just passed her CPC exam. Congratulations, by the way. And it seriously brought tears to my eyes. The kind words and truly just making me feel like I helped you in some way, and how you told me you get inspiration from what I'm doing out here on the CodeCast and different things on the platforms that I'm involved with. I really appreciate that. So thank you again for that wonderful email. I can't tell you how much it means to me. Okay, everyone, on this Terry Tuesday, thanks for spending some time with me again. Make it a great day and a great week. And until next time on the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.